Welcome viewers, good morning. Today we have two distinguished speakers with us, and their faces are familiar to you. On my left is Dr. Bidhan Das, who is a senior hospital administrator and consultant, and on my right is Professor A.K. Sood. You are familiar with Professor Sood. He has been helping us in the teleconferencing sessions for a long time. And today we have discussions on 2-3 important topics. First we will discuss course 3, and in that I have requested Dr. Bidhan Das to discuss with you or to present about the role of hospital administrators and also a bit about the problems and issues in hospital management. Then we will have a break at 11:45, and then from 1 o'clock I have requested Dr. Sood to take 2-3 important topics, like the course 2 we have block 1, which is about the financial management, and that deals with budgeting and cost containment, and also there is a block, second block is dealing with marketing and health economics, so he will discuss a little bit about marketing as well. So we will have 3 sessions, and each session will be of 45 minutes. And let me tell you that we just finished an international workshop in IGNOU on healthcare waste management, and we had, as IGNOU has launched a certificate program in healthcare waste management in the Southeast Asian countries, and this program is already on offer in India as well as in Bangladesh and Nepal, and we also propose to launch it in a few more countries. And in this workshop we had delegates from Nepal, Bhutan, Indonesia, Maldives and India. And healthcare waste management is assuming a very great importance. As you remember, some time back there was a United Nations Basel Convention, and this Basel Convention had described, that was about the transboundary movement of the hazardous waste, and this Basel Convention in Switzerland had resolved that healthcare waste is the second most hazardous waste after the radioactive waste. And the WHO in various studies has described that annually there are so many million of hepatitis B, hepatitis C and HIV infections which are caused on account of needleistic injuries and on account of the hazardous waste irresponsible disposal or irresponsible collection, segregation, collection, transportation and treatment of the biomedical waste. So this was just for your information, and now without taking any more time I will request Dr. Bidhan Das to please present, to make his presentation about the topics that we discussed.
Thank you, sir. Morning to you.
Good morning.
We start straight with the hospital as an organization, and as you all know that typically any kind of hospital, whether it is a public or private, we have 3 lines of authority. I think we can, yeah, that's better. One is the governing body. The governing body looks after the moral and legal aspects of the organization. So any organization, obviously it has to have some licenses to conform with the regulations and legislations of the state, since health is a state subject. Moral means moral as well as ethical issues that are really governed by the governing board. Well, there are other divisions of the governing board which could be created, and one of them could be ethics committee, which could look at the ethical issues of the organization. In this case it's a hospital. Second, we have the administrative staff who are responsible for the resources, resource mobilization, or they are the staff functioning, and they are not the typical line functionaries. And in that case, we have the finance department, we have the finance and accounts, which we will be discussing today, we have the HR department, we have the housekeeping department, and so on and so forth. And of course, it is headed by a typical position, which is either a director of the hospital or a medical superintendent of the hospital or a CEO of the hospital, and so on and so forth. There are very many nomenclatures that could be given to this kind of person who is heading this services. And third, of course, it's the professional services, which is usually clinical and non-clinical. Therefore, when we talk of clinical and non-clinical, we have a typical divide of clinical, supportive, and utility. Somewhere we also divide a clinical is the clinical services like medicine, surgery, orthopedics, gynae, pediatrics, and so on and so forth. Support services are the lab, imaging, and other support services. Utility is, of course, the other services that we are talking of, like housekeeping, pharmacy, manifold, engineering maintenance, and so on and so forth. These are the typical divisions in a hospital organization. Now, what are the factors that influence the typical hospital care? Now, we are all used to this diagram, which is called the structure, process, and output, or input, process, and output. And this is how the governance of a hospital usually takes place. And this is typically used in a to establish a quality system in a hospital. So therefore, what is the input, what is the process, and the output? I'll deliver first on the input. Input means what are the structural components of an organization or a hospital in this case. Now, a hospital has typical structural connotation. One is the physical facilities, the layout, the land, the building, the electricity, the water supply, the backup sources for electricity, the backup sources for water. And then we have the staff, we have the equipments, we have the drugs, we have the licenses. So these all together encompass the typical input in an organization. Well, in the process, how the activities are carried out in the organization. So what are the processes that take place? We have typically admission process, the registration process, the admission process, and then the patient undergoes the surgeries or treatment and so on and so forth. And last, of course, we have the discharge process. Now, in between, we have the transferring process, we have the intramural transfer, the extramural transfer, the waste management, the infection control activities. There are a myriad of activities. All these encompass the processes. Now, what is the output? Now, output is typically what we say as what are the rates, let's say. There are two kinds of output. One is the managerial output, the other is a clinical output. And therefore, we call them as managerial indicators or clinical indicators. In a typical clinical indicator, we can have cesarean section rate, which talks about the quality of the hospital, the services provided by the hospital. We can have re-entry into the operating room. We can have ADR, adverse drug reaction. We can have transfusion reactions. We can have number of needle stick injuries, as was spoken by Professor Agarwal. Then we have the managerial indicators of the managerial output. What is the bed occupancy rate? What is the OPD attendance rate? What is the infection rate? What is the bed turnover rate? What is the utilization rate? What is the patient satisfaction rate? What is the employee satisfaction rate? So these are the output indicators. So we have a clear divide as to what is an input or a structural component, what is a process component, and what is the output component. Now, what are the variables? Now we talk of the variables. So in the variables, we have number one, when we talked of the physical factors, that is the land, the building, and so on and so forth, we talked of the staff as well. So what are the staff? The staff are we have to divide the staff into doctors, nurses, technicians, administrative staff, and support staff. And everything, the staff is usually based on a workload. Earlier on, we had norms for a primary health center, staffing norms for a primary health center, a district hospital, or a community health center. But nowadays, the modern management, we have spoken of utilization. What is the load of the hospital, and therefore how much should be the staffing? And the staff should be utilized optimally. So it doesn't make sense that there is a good amount of staff, the hospital is full of staff there, but there are no patients. So it depends on the load of the hospital, and therefore the apportionment of the staffing, whether it is a private sector or a public sector, should be according to the load. Now, how a load is calculated? When you forecast the business plan of a hospital, which will be spoken by Professor Sood later, we forecast 25% occupancy, 50% occupancy, 100% occupancy. So the staffing, how much staffing are you requiring, or would you be requiring at 25% occupancy, at 50% occupancy? So therefore, it is clearly forecasted how much should be the staffing, and which is based on the workload. So it is on the pay, or else we can have a doctor. How many doctors per patient? So we have some norms. The norms are 4:1, 5:1, 1:1, and so on and so forth. The nursing norms by mentioned by the Nursing Council of India and some by the Medical Council of India. Now, since the human capital is very important and it is almost equivalent to a capital assets of a hospital or as an organization, we must develop them. So we must develop them. That is the one is recruitment, and we also do the career development, their education, their training further. Physical, these things we have discussed, clinical and service, effective use of bed and resources. Effective usage of bed and resources, which is a managerial indicator which I have told you, we must always make use not only for the manpower but also of the resources. So we have a CT scan. So the CT scan is operational 24 hours of a day. It can be used, an ultrasound machine, an MRI machine which can be used 24 hours a day. So how much are you utilizing? Are you utilizing 25%, 50% or maximum capacity of the CT scanner? So how do you calculate? So there is a method that how you calculate. What is the process time, what is the in time, what is the out time, and divided by 24 hours. So you can in a day, let's say a CT scan, the procedure time is 15 minutes, in and out time is 15 minutes. Together it becomes half an hour. So in a day, 24 hours. So we have maximum capacity of working and doing, let's say 48 CT scans per day. So supposing we are doing 7, we are doing 8, we are doing 10, we are doing 12. So therefore we can calculate how many CT scan and what is the percentage utilization of the CT scanner. That is of the equipment. The same can be utilized as a utilization ratio for the space. Supposing it's a 10 bedded ICU. So 10 bedded ICU we have, so 10 into 30. It is 300 ICU bed days. How many bed days are occupied? And if the ICU bed days are occupied at the rate of 25%, what intervention shall we take, intervene, so that the utilization rates are increased? Because ICU or the operating room of a hospital are the highest resourceful area of the hospital, and therefore they should be utilized more and more. Now these are the concerns, or these are the role. This is the typical role of a hospital manager or a hospital administrator. Quantum of load or quantity of work, the workload, and of course leadership and motivation. Leadership and motivation we have discussed again and again. That is something which is a typical art of how your leadership skills you possess, how are you motivating the total staff of your hospital, keeping their morals high and thereby increasing the productivity. Now let us see what is the typical role of a hospital administrator. Now, governing body, it's a provider. So provider does provide. What do they provide? Doctors, nurses, paramedical staff, equipment, and so on and so forth. What are the recipients? The recipients are recipients of services or recipients of healthcare, and mostly the recipients are the patients locally or community at large. And the interface, as you can see, the interface is the administrative staff, or the leader here is the CEO or the director of the hospital, or maybe the medical superintendent. The medical superintendent or the CEO acts as an interface between the provider and the recipient of healthcare, and of course the governing body. So he has to be the middle and be an interface amongst this triad of the. He has to report to the governing body. He has to be answerable to the patient and to the community needs, and he has also to be answerable to the doctors, the nurses, and the staff of the hospital. So in this triad, he fits into the middle, and therefore he has to. And typically we call him as an interface between all of them. Now, what is the internal operation? Internal operation of an organization is organizational planning and development. We have talked of planning and right from the inception stage, and how the person, the leader, or the hospital administrator or the manager of the hospital has planned, and then how he is developing and implementing the same plan which he has envisaged. Efficient operation. Now, typical efficient operation means operation management of an organization. So how is he encompassing this activity of operational day to day, and it is not firefighting, it is not troubleshooting alone. It has to be a planned activity, and then it is seen that all that has been planned has been implemented in the same way that the plan. Of course, there are issues and concerns sometimes off and on, that as and when there is some ad hocism, there is some firefighting, there is some troubleshooting, which are, routine affairs. But in case the systems are there in our organization, typically the process management is taking place, and which will reduce all this firefighting. I mean, no one would say that there will be never a day where there is no firefighting, there is no education, there is no, so there will be. But then, if the systems are well planned and well designed, I'm sure these issues will not crop up. Cost containment. Cost containment is another issue which will again crop up in the second part of the discussion today. And Professor Sood will look after this, and we will all participate in how do we achieve this cost containment and increase the revenue from alternate sources of revenue. Cost containment, and that aspect will talk. Increase in productivity. Now, productivity is something that and productivity is by the manpower. Productivity, the equipments are there. If they are used, they will be productive. But the issue is the manpower. The manpower has to be productive. So in that much time, in that many 8 hours of that person, he is producing maximum output. A surgeon, a CTVA surgeon can do 4 surgeries, let's say, bypass surgeries or open heart surgeries. He has achieved maximum productivity. But we do not have the resources, and we do not have the input, we don't have the patient load. If the man is there, the equipments are there, so his productivity will come down. Now, why is motivation important? Motivation is again important for increasing the productivity. We have manpower, but they are not really motivated. Once they are not motivated, they will not be productive. And then it comes to an organizational loss in terms of output, profitability, or profitability is both in public sector and private sector. Private sector, it is in monetary terms, and in public sector it is in developmental terms. In terms of number of people who have utilized the hospital, who have taken the services of the hospital. So productivity is quantifiable, it is measurable. Now, other activities is community participation, load of patients, and of course marketing. Marketing we will be discussing again in the second session. So,
but here, if I may just interrupt for a moment, it's a very useful discussion, viewers, which is going on, and Dr. Bidhan Das is saying that in the hospital we have the different resources, the human resources there, then we have the equipments, machinery, and he gave example of the CT scan, etc. And then we have got the financial resources, and as well as finally he is talking about the leadership and motivation. So you see, the utilization of these resources is something very, very crucial, and particularly in the public hospitals, if we see, that's where the indices that he mentioned, the structure, process, output, or input, process, output. In the output, certain things are measurable, certain are not measurable so easily. But we can measure certainly the bed occupancy rate, average length of stay, the death rate, the bed turnover rate, and the bad days, all those kind of things. But when it comes to the quality of services, the patient satisfaction, the hospital acquired infection, some of it is measurable, but some of it becomes very difficult to measure. So the role of the leadership plays a very vital, role of the leadership plays a very important role, and then also the motivation of the people. And here I would like to invite comments from both the experts that are sitting on the dais, is that you see, we take example of a typical state health cadre, whether it is state health cadre at the state level, provincial level, or at the central level. At the central level we have got the central health service, and in the states we have the provincial medical services. And for example, because the doctor is the leader of the team in any situation, whether it is a primary health center, or it is the Directorate General of Health Services, or it is a big hospital or a medical college hospital. So this leadership role played by our colleagues in different positions of the hierarchy is something that has to be scrutinized and that has to be looked into. Why I am saying so, that the leadership over this since the time of independence is been questioned by the community, has been questioned by the policy makers, and when we put a doctor immediately after his or her graduation or the post graduation, they come from the ivory towers of our apex medical institutions in the country, whatever, whichever place they are, and they are suddenly put into the health system, whether it is the primary health center level or community health center or the district hospital or the medical college hospital. And this person who has come either as a specialist or as a assistant professor or as a general duty medical officer is at loss in the organization. He doesn't know the systems, he doesn't know the government functioning, he doesn't know how the hospital is working, and that person is really not giving or is not able to give. So I feel that the systems in which he has been put, he has not been given any orientation to the system of the hospital or to the healthcare delivery system, wherever he is posted or she is posted. As a result of which we are not able to extract the maximum of this human resource which is so competent, which has been trained for about 7 to 10 years in medical colleges. So what do you feel, Dr. Bidhan, that how can we overcome this, and whether this is a problem or not a problem?
Sir, both of you, I mean both you and Professor Sood, both of you are now exposed to public sector. Now with our experience there, we are very clear that this kind of induction program or induction training program or socializing program doesn't exist there. However, the hospitals do have some kind of training program on account of national health schemes, let's say pulse polio, the RCH, these kind of training programs are there. But peculiarly, we have no idea as to, I think you will be, or Professor Sood can comment, as to why this kind of induction training program doesn't take place when a doctor is inducted into the services. A young doctor, we have seen, sir, after graduation is posted at the primary health center, the community health center, she has no, or he has no idea. See, we asked and they say, oh, we have just been put here and we start working without knowing, and all that they are interested is, is documentation, filling up the immunization, how many people have come to the OPD and so on and so forth. I think I would put it to Professor Sood to comment on that, sir.
Thank you, Dr. Vidyandas. As Professor Agarwal very rightly said, management is a very important, I think, job which is expected from a doctor, whether he is placed in a primary health center setting or in a hospital setting. But unfortunately, during our MBBS training or maybe specialization as well, except for hospital administration, there are hardly any efforts for management, because whether the doctor is placed in a primary health center where you have to have lot of other functionaries, like you have health assistant, you have health worker, you have to deal with community, you have to plan for resources other than your clinical skills. Yes. And sometime as a doctor at a primary health center, you have to play more of a leadership role and more of a managerial competencies are required rather than your clinical competencies. So that deficiency is definitely there, but it is good that the institution like Indira Gandhi National Open University has come up with this program, which I think gives opportunity to all the doctors who are either in private service or government service, opportunity to at least acquire these competencies. Many a time we acquire these management and leadership competencies by trial and error method based upon our experience. Because still now in the government setup, your administrative positions are usually given by your experience or seniority. Dr. Vidyandas mentioned about medical superintendent. In most of the government setup, the medical superintendent usually is the senior most professor. He may be from basic sciences, he may be from clinical sciences. But very few, I think, especially in the government sector institution, have this post reserved for people with managerial backgrounds and administrative backgrounds. But gradually the changes are coming. Of course, in the corporate sector hospital which are coming up, the posts have been exclusively kept for the administrators with administrative and managerial backgrounds. And government setup, of course, will also gradually take over this, because the resources again have been a big constraint in the government sector as well. And now the thinking is going on how to sort of utilize these resources, because the funds which are being allocated to the government sector, whether it's a medical college or hospital, they are gradually decreasing, in fact, in some of the states, and the government is not able to provide even the plans which we have, the policies document which say that the investment of the government in health sector is not as per the, even if you look at the per capita investment on health is very less as compared to the other countries. So this thinking is gradually coming up, and over the period I think the administrative positions will be created as a cadre in the hospital as well. And till that time, I think the supplementary programs like this management programs by IGNOU and other institutions, I think they are playing a very important role. In fact, once you acquire some additional, because management concepts and principles are universal. Most of the time we think that these are applicable only to the business sector, but these concepts and principles are universal and applicable in all sectors, including the health sectors. Basically, we are dealing with human beings. We are dealing with, as Professor Vedanta said, that we are dealing with resources in terms of money, in terms of material, in terms of equipment and human beings. So wherever you are placed as a primary health center or district hospital, you are interacting with these resources, and your performance as a leader is determined how efficient you are or how effective you are. So unknowingly we are using those concepts of management and principle in whichever capacity we are working, whether a head of department or head of the unit or a primary health center in charge. And these concepts and principles, as I said, are universal, and if we use some of these things in our day-to-day practice, that will increase our efficiency. And I think these are some of my observations, that over the period of time the change will come in the government sector as well. Right now it is the private sector, big hospital, corporate hospital, which are taking care for selecting positions as medical administrators.
Thank you. Thank you. I think that was a good discussion, and I deliberately wanted this to happen. And the reason is that, you see, unless we have, and very rightly both the experts have nailed the issue, is that the induction training before we put, or just after the recruitment of the doctors or the nurses, you know, all these staff, some induction training should be carried out in the organization wherever they are posted. For example, if the doctor is posted in the district health system, whether it is hospital at the district level or CSC or PSC, I think there should be a 1 week's at least induction training at the district hospital, followed by the place where he is going to be posted, so that he comes to know what is the district health organization. Similarly, in the hospital, if he is posted, he or she is posted as a gynecologist or a general duty medical officer or a casualty medical officer, I think we need about 2 weeks orientation training, induction training, so that the person knows about the objectives of the organization. And this is not true of only the public hospitals, even in the private or corporate hospitals, induction training programs are absolutely necessary. It may not be necessary for a visiting consultant, I can understand, but for a regular doctor who is there as a regular employee of any hospital, some sort of induction training is very important. Motivation, leadership qualities have to be inculcated. Management training courses, as Dr. Sood has highlighted, they need not be a 2-year or 3-year or a 1-year program, but we can have short capsules wherever it is not possible for the state government or the doctors to undergo long courses. I think a 4-week, 3-week, 2-week courses. In the National Institute of Health, there are courses where people are nominated. That is a 3-week hospital administration course, then the staff college course. I think these are the things which are very, very important, which probably our health planners, administrators at the state and central level, as well as any other place, they have to take note of. Thank you, please.
Thank you, sir. I couldn't agree more.
Sorry, just a few points. In fact, in some of the states, before the doctors are inducted in the service, they are given exposure, as Professor Agarwal said, about the induction training.
Yes.
I remember in Punjab, Haryana, there is a provision for induction training, placing them at various levels so that they actually get what is happening in reality. And as you said, that we have institutions at the state level now, state institutes of health and family welfare have come up in almost all the states. Then district level training centers are also available in most of the states. So we have a fairly good network beside medical colleges. So I think there is perhaps more sensitization is needed at the planning stage, whereby we should plan for not only induction training but also for a regular in-service training program. Because once a person joins a setup, whether in government sector or private sector, and over the period of time as he gets promoted or given new responsibility, he need to be given orientation program, maybe 1 week, 2 week or 3 week, as you said. But this should be as a part of their human resource development strategy for the hospital or for the organization. Thank you.
All right. Thank you, sir. I think I couldn't agree more than what both of you have said. Now I'll like to draw your attention to this slide. Some managerial skills which the manager should possess, and as Professor Sood said, management principles are the same, whether it is a business organization, and the hospital is also a business organization. So the problem is, what we can face right now is, most of us complain that in the private sector, the corporate hospitals are managed by people who are not doctors, and they are business managers.
Can we have the slide, please?
Yeah, that's better. So the issue is, the person should be good in general management, and why? So this slide is very familiar to all of you. One is that conceptual skills, the human skills, and also the technical skills. People at the lower level, or when the person is inducted, he should have a lot of technical skills, and he should be very good in his whatever. He is a nurse. If he is a nurse, if he is a doctor, he must be a good nurse. He must know the principles of nursing. He must have good bedside mannerisms if he is a doctor. So technically, they must be very, very sound. The top man should be very good. A lot of it should be conceptual, and then he should have very little of technical and a significant amount of human skills. Now, conceptual skills, here is the difference. Now, if the manager of the organization, which is a hospital, is a medico or a doctor, he would have naturally a lot of conceptual skills of all the clinical services, the support services, the managerial services, the administrative services, the finances, and so on and so forth. That is the differentiator. Now, a person who is not a doctor will not be able to appreciate the clinical concepts. So here you will lack the conceptual skills on account of medical practices. Well, rest everything is probably the same. The middle level person should have good amount of human skills. I mean, he should have good interpersonal communication. He should have good human relationship with each other. So this slides must be, all of you must be conversant with conceptual skills, human skills, and technical skills. Now, what are the reasons? So we'll discuss quickly for the changes in the healthcare sector. Now, in terms of, a lot of it was now discussed for the finance, and Professor Sood addressed the idea is there's a deficit in the per capita expenditure on account of healthcare for the government of India. Well, this is a deficit which is worldwide. I mean, no one is as rich, or be it the private sector. In the private sector, we have to spend the money, and so as to earn the money within a separate period of time, and therefore we'll now quickly discuss in the second session break-even analysis. When do you want to break even, and what are the types of break-even analysis? So that we will be discussing. Now, shortage in terms of finance with the governments to meet the increased demands and the expectation of the citizens. So there is a deficit. Well, it is a national issue, and we can do very little about it unless the economy of the country. But then some of the states are quite rich. There is a differentiator. Some states are wealthier, wherein the per capita income is more, and in that those states, the health budget is more, and some states are not all that. But increased awareness to quality resulting in increased demand for quality. Now, this is something a growing development now, which is, I don't think it will be issue. It is a development, and now the country. Most of the states are exposed to what is quality, the concepts of quality, and some of the states, and with the NRHM coming in, there is a lot of impetus on accreditation. Therefore, a couple of states in the country are also now interested for accreditation, for the national system of accreditation. Lack of friendly customer services in government facilities. So this is now increasingly seeming to be some of the states which are now exposed to quality. They are now making certain interventions as to how to be more customer friendly. They are having citizens charter, they are having signages, they are having a nice facade, they are having a welcoming attitude. The patient patient feels invited. I mean, not that earlier the facilities were not that. Earlier it was more of an IEC, but then nowadays it is now changed into more of this kind of thing, and now the patient feels invited. Waiting time. Well, waiting time is an issue everywhere, whether it is the OPD, the operating room, the ward, So it is a good idea for the hospital manager to assess and monitor the waiting time and intervene if the waiting time is long, or even if it is not long, intervene to make it shorter, and thereby increasing the patient satisfaction month after month or year after year. Lack of modern and appropriate equipment in public hospitals. Well, this is an issue, and sir, this is, I think I need your comments, because public hospitals, they have one differentiator, and that is they don't have a post of a biomedical engineer. They do have equipments which is by all means how they are procured. We have an idea. Some of the equipments are excessive in excess in nature. A lot of radiant warmers to be found, a lot of CT scanners to be found with in the absence of a radiologist, in the absence of a pediatrician. There are radiant warmers, there are ventilators, they have an NICU. Well, there is a skewed approach of equipment procuring. Now, in the absence of biomedical engineer, this is a concern, and no one has an idea of an AMC, no one has an idea of the calibration, which is and very soon the equipment is getting defunct.
I think this is a very, very important issue, and I couldn't agree less with Dr. Bidhan Das. You see, there was a study which was carried out by Department of Electronics, Government of India, way back in 1991, and this hospital was surprisingly carried out by Department of Electronics, not by Ministry of Health, and all over the country, selecting a sample of about 10 states including Delhi, and then in south Tamil Nadu, and then West Bengal, Assam, and then Punjab, etc. So cutting across the whole country, and this study was being conducted when Mr. N. Vittal was the secretary of the Department of Electronics, who became the Chief Vigilance Commissioner later on. And this study revealed that, as I mentioned in the last teleconferencing also, if you remember, that as much as 40 to 50% of the hospital equipments in the public hospitals across the country are lying non-functional for want of simple maintenance, repair, spare parts, etc. So this is a very careless wastage which has been probably ignored, and our hospital administrators, particularly in public hospitals, are not seized with this. They have very little idea. They are not, they are so little sometimes indifferent to the whole issue of the equipment management, because they say they are not knowing anything about the equipments. I don't say that the medical administrators should know the ins and outs of the equipment, but then certainly there are processes, there are ways that how the equipment has to be selected, how the specifications have to be decided, how the tenders have to be floated, the technical bids, the commercial bids. I think all those things, as a manager of the hospital, you are supposed to know. And therefore the annual maintenance contract, about the biomedical engineer, this is a crucial issue in the hospital management, in the hospitals, and I am very happy to share with you that biomedical engineers have been recruited. I know of at least a state, Tamil Nadu. Tamil Nadu has got a Tamil Nadu Health System project, which I happened to visit a number of districts as on the invitation of that government, and 5 biomedical engineers, young biomedical engineers, have been recruited only to look after this equipment management, and I think this should be followed by the other states also.
Thank you, sir. The second issue is again the aging population that need more efforts and services. We all know that the quality of life, the DALI of which are the indices worldwide, and the senile population in our country is increasing. So there is a captive audience of senile population which visit the hospitals, and they are, colloquially we call them as vulnerable patients, whether they are senior citizens or elderly people or children. So particular attention should be given to the meet of their needs. Now, simple things like, a separate counter when the government of India is giving them facilities in terms of discounts in the railway fare, the air fare. Why can't the hospitals give them a separate counter? These are some which will go a long way. Inability of the government to attract and retain the best of doctors and other staff. It is a phenomena. It is across the country, pan-India. No state government is able to retain the doctors. They are not able to fill the vacant post, and in spite of the best of efforts and concerted effort by the secretary, the principal secretary and the minister, they are unable to fill up the vacant post. Thereby, this is a concern, and it will probably remain. I can comment about it. I think it will remain. We don't see that to be filled up very soon. Inability of the government to attract and retain the best managerial talent. Well, the same principles also apply. Now, methods of financing, some innovation on accounts of methods of financing, because ultimately it is money that is going to matter. And irrespective of the fact whether it is whether it is a Rogi Kalyan Samiti, the user fee, I mean whichever hospital has a little bit of financing scheme, it is always better. Management consulting and contracting. Not all the managerial abilities are available with the hospital management and are necessarily not to be there. So in case when you need some support or help, we can certainly, and there are means and ways as to how to avail these kind of services, either by contract in terms of PPP or in other modes of BOT or BOR and so on and so forth. New treatment protocols. Yes, the hospital chief or the medical superintendent should be oriented to the treatment protocols or clinical pathways. We should adhere to some of them, minimum nationally, if not international treatment protocol, at least the national treatment protocols which are available. I mean, FOXI has, Indian Academy of Pediatrics also has treatment protocols. All these professional bodies have treatment protocols. So we should adhere to some of the treatment protocols clinical, and that will ascertain the standards of quality of the clinical services. Outsourcing of certain service functions, I will not deliberate on the outsourcing because then it will take a lot of time. What will happen? Ultimately we must get a shift to the outpatient treatment or the daycare treatment, wherein the bed turnover rate becomes more, the bed occupancy rate becomes more, and the average length of stay becomes lesser. So these are the indices that we should monitor and gradually see the improving, and thereby ascertaining a principle of continuous quality improvement. These are technology acquisition. We did greater attention to cost and accountability. Accountability in terms of services, increase in patient involvement in decision making. So therefore, consumerism. We must be first exposed to what is Consumer Protection Act ourselves, as a hospital manager, and also treat the patient as a potential consumer, whether he pays or she pays for the user fee or not. Irrespective of that, we must treat the patient who is availing of our services, and we are for sale. We have a marketability. Our market value increases only by the number of patients that we see or we service. Greater utilization of more sophisticated equipment, which we have discussed earlier. What are the result of these kind of changes? Greater involvement of professional management companies. We can take the help of professional managers, higher standards of patient care, more accountability, better quality of services, greater efficiencies, lower treatment cycle cost, greater access to the public health facility or the private health facility, either. I mean, both are equally striving for this kind of access. The private sector is wanting patients only for the profit, and the public sector is wanting more number of patients to show that yes, these many patients are availing of our services. Not only, it doesn't only mean that institutional deliveries have gone up. No. It has to be across the hospital. Institutional deliveries are a very small component of the healthcare facility. Additional investment in healthcare facilities and technology. Improvements being made in existing public health facilities to compete with the private health. So now we are upgrading some of the public health facilities, and mostly they are district hospitals across some of the states, and they can probably compete with the private health facilities. Some problems in terms of hospital facility planning and operational performance, planning standards, impact of technological advances in facility planning, safety, patient safety and staff safety, future expansion, human resources. Professor Food had discussed and Dr. Agarwal, Professor Agarwal discussed. Sources and selection, recruitment, manpower training and development, planning and staffing issues, attrition and retention, staff motivation and staff satisfaction, HR policies and HR policies are, there is a manual, but then there are no defined HR policies, job specification, rotation and job enrichment, labor unions and strikes, financial management are deliberately leave because financial management will discuss later. IT, I think again we can leave because IT is probably, but then yes, we can go into hospital information systems, we can talk of digitization, we can talk of PACS and so on. Maintenance we have discussed in terms of biomedical engineering, but then other issues are also there. Fire and safety, power backup, store management, and some regulations. Regulations are the licenses. It is irrespective of the public and private hospitals. All the hospitals should have the licenses which are required for a hospital. Ergonomics, signages, lighting, housekeeping, waste management.
I think we can continue with the same discussion little later, and I would remind the regional centers and the viewers across the country that they should try to let us know that if they are listening to us, and raise any questions if they have, because we have the experts to answer to your queries on these 2-3 important areas. We will again come back to you at 1200 hours. Thank you very much.